So I'd like to open today's seminar by acknowledging the traditional custodians of the land upon which we meet today, the Gadigal people of the Eora Nation, and pay my respects to their elders past and present, and extend that respect to other Aboriginal and Torres Strait Islanders who are here in the audience with us today. So welcome everyone to today's seminar on universal health coverage. For external visitors, and I think we do have a few, I'll just begin by saying a couple of words about the George Institute. As many of you know, the Institute is focused on the biggest burdens of disease, the biggest killers, and it's well known for its work in particular on NCDs and injury. And we have a long-standing reputation for world-class research in these areas, but also on the practical application of that research, translation into policy and practice. Linked to that, we have an expanding area of research on health systems, and I'm a recent addition to that team. It's a growing team, and interesting programs of work on health financing, human resources, mHealth, and other areas, primary healthcare I'm working on in particular. But overarching all of that, spanning all of that, is a sort of interest in universal health coverage and how what we're doing here helps to achieve that agenda of universal health coverage. So we're really thrilled to have Daniel here from the World Bank to give us a seminar on that topic. The seminar is organised as part of a series that's been organised by a relatively new initiative here at the George called George Institute Think Tank. And the aim of that think tank is really about research dissemination, not just our research, but research from others too, stimulation of discussion and increased collaboration. And there are 4 areas of research under the think tank: women's health, healthy living environments, which includes nutrition and injury prevention, health systems, which this seminar falls under, and social enterprises. And just as a short digression and plug, next week, the second seminar in this series, also organised by the think tank, will be given by distinguished fellow Trish Greenhow, who's a respected expert in primary healthcare from Oxford University, and her lecture is on collecting stories and narrative research to capture cultural context of health, and it will be here on the 23rd of March at lunchtime, and you're very welcome to attend that seminar as well. But today we're thrilled to have Daniel here. Daniel Cotlear is lead economist at the World Bank. He's based in the bank's health, nutrition and global practice, and his work is around supporting countries to advance policies to achieve universal health care, and also has a particular focus on population ageing. He's manager and chief editor of the bank's Universal Health Coverage Studies series, which I believe will be presented here today, and holds a Doctorate of Philosophy from Oxford University and a BA from the Catholic University of Peru. After Daniel will speak for about half an hour, and after Daniel we will have Dr. Virginia Wiseman as our first respondent. Virginia is Associate Professor of Health Economics at London School of Hygiene and Tropical Medicine, based in the University of New South Wales, and also co-editor of the journal Health Policy and Planning. And Virginia has 20 years' experience as a health economist, conducting research on health systems financing and delivery in low and middle-income countries. And her current research focuses on 2 themes: health systems financing and the evaluation of complex interventions. After Virginia, Joel Negan, who is head of school and associate professor of international public health at the University of Sydney. And Joel's research focuses on health system strengthening in resource-limited settings, with a particular focus on infectious disease and ageing populations. We've got until about 4:30, so we hope to have a good discussion after that for those who are able to stick around. So thank you. I'll finish by thanking everyone for joining us today for the first lecture of the Think Tank series. If it does spark new thoughts or reflections, please add to the conversation on the Twitter hashtag George Talks. And now, join me in welcoming Daniel to the floor.
Thanks so much. Hello, very pleased to be here, and I will try to tell you a story based on 40 different stories of countries that are trying to implement universal health coverage. This is the result of the work of many people, which we call the UNICO team, About 150 people have been working on these individual country stories. So maybe. Okay, so I'll start describing very briefly what UHC is all about, then tell you a little bit about this particular set of studies. Where do countries normally start when they launch a UHC program of reforms? And then what the reforms consist of. What are the commonalities? What are the differences when one looks across countries? So where the MDG targets, we're now moving, or the world has now moved to the SDG targets. And in health, this has three big changes. One of the changes is that the MDGs were focused on mothers and children. The SDGs are focused on people of all ages. Second difference is that the MDGs were focused or emphasized promotive and preventive. UHC is interested in promotive, preventive, curative, rehabilitative, and palliative. And finally, UHC adds a dimension that was not before in the MDGs, which is it's not just about covering essential health services, it's also about financial protection for all. So these are some of those two indicators for countries in this region. You can see that East Asia and the Pacific, in terms of coverage, are ahead of other regions, but are not, still have space to grow in terms of expanding the coverage. There's very big differences across countries. Very high levels of coverage in China, Thailand, and Vietnam, much lower levels in Papua New Guinea, Timor-Leste, etc. And if one looks at the financial risk protection, you can see that there's a very significant part of the population that becomes impoverished because of medical costs. The worst problems of impoverishment take place in South Asia. East Asia is, however, fairly close to the second place, or it is in the second place in terms of World Bank regions. There are, again, big differences across country. Cambodia and China, very significant. Thailand, Malaysia, and Mongolia, much lower. So this is as a way of background. The way the bank reads this is the world is now committed to universal health coverage. However, these figures suggest that there's a huge amount of space, that the challenge of achieving universal health coverage in terms of impact is still ahead of us, or largely ahead of us. So the UNICO case study, we were not trying to measure, and we were not trying to establish impact. We were trying to understand what policies countries are implementing when they say that they're trying to move towards universal health coverage. The emphasis was trying to understand what keeps the policymakers awake at night. And we tried very hard to understand in each country how the system, what the system does to be progressive, to be more pro-poor, to be inclusive of the poor. We produced 2 rounds of studies. The first was 24 studies, and only 2 weeks ago, we launched a second group of 15 studies. And so I'll tell you some of the main results about this all. Universal health coverage is usually described by this now famous UHC cube, which basically says coverage has really 3 dimensions. You want to coverage more of the population, you want to coverage more of the services, and you want to make it more affordable. And the UNICO study covers those 3 things, how countries do those 3 things. But in addition, we also try to understand how countries try to expand the supply of services when that's the problem, or the quality, and how countries try to strengthen accountability, which in many places is the main problem, or is perceived as the main problem. These are the countries we covered. The first round in green, the second round in blue. And in this second round, we tried to do like a light exercise covering all of Africa. So the African countries covered are also there. And you don't have to read all of this, but these are the specific programs we tried to understand in care. And the main features that I wanted to highlight out of this table is that the first is that of the 40 programs, 33 were launched in the new millennium. So they're relatively young programs. Secondly, the coverage is now 2.6, 2.7 billion people. That's the coverage of these programs. So these are not pilots. These are very large and cover 1/3 of the population now. So that's the first big message. When you look at the UHC reforms today, you can see that they're new, they're massive, and I will try to show that they're also attempt to be transformational. Usually, when we started this work, the question was, there was some debate about where countries started. There was a lot of literature that was giving advice about what the first step should be. And after we did the study, we realized that countries are not really starting at 0. So they usually don't need advice about the first step because they've already taken the first step. The advice they need is about the next step. And specifically, 2 important characteristics that most of the 40 studies share are that countries were starting with a fairly extensive coverage of a universal basic package. This is a basic package that was focused mostly on preventive interventions addressing communicable diseases and mother and child care. And so most of the countries we've analyzed are countries that launched their UHC reforms in order to go beyond this. Second big characteristics is that when you look at how countries were spending public funds, you find that the spending was quite regressive. You also find that if you look within the public systems, spending in primary health care and in community care tends to be much more pro-poor than spending in hospitals and in tertiary services. And so the UHC reforms acknowledge this as a starting point and make an effort to reach the poor, to be inclusive of the poor. And they do it in 2 different ways. Some of them look at the data and they say, well, primary care, community-based care are the most pro-poor, so obviously what we need to do is expand that. That way we will reach them all. Other countries look at the same data and they say, no, what we really need to do is we need to make sure that the hospitals do not stay closed to the poor. We need to find a way of opening the gates of the hospitals and tertiary care to the poor. The first path aims to expand the supply of the pro-poor services. We call that the supply path, the supply side path. And the second one aims to give effective demand to the poor. And we're calling that the demand side path. So now let me tell you a little bit about some areas of convergence and divergence between all the countries we looked at. And this is looking at the cube again. One area of convergence we find is that almost every country we studied, when they launch the program, they make 3 promises. One of the promises is about the population they intend to cover. And usually this comes with numbers and with dates. Countries in this region, I understand, have, for example, Indonesia, made the commitment to reach universal health coverage by 2019. Second promise is about what coverage in terms of benefits they intend to provide. And most of the countries have moved to making these promises in the form of an explicit benefit package. Not just will give more, but often what it is that they promise to provide. And thirdly is they will reduce user fees at the point of service for the benefit package. There's a lot of talk now in the development community about developing an accountability framework for UHC reforms. And sometimes I wonder if these, making sure that these 3 promises are being kept would be a good starting point for that. So now looking at the side of benefits regarding trends in strategic purchasing, we find, as I said, that most countries aim to provide coverage beyond the essential MDG interventions, but the next set of priorities is unclear. And let me describe this with some findings from the Africa work, which, by the way, I did together with Nicolas, who's joining us here. And 44 African countries, most of them, almost all of them, now include in their benefit package, in their universal, that means free at the point of service benefit package, immunizations, interventions against TB, AIDS, and malaria. At a lower level, but still with a lot of consensus, there's the RMNCH set of interventions. Beyond that, there is no consensus. So countries are trying to go beyond these 2 sets of interventions. Some of them are going for other primary outpatient care. In some cases, that includes NCDs, but it's only 20% of the countries. Other countries have decided that what's really important as a next step is inpatient care, other specialist care. So no consensus about what the next set of interventions should be. What seems to be happening is, however, all these countries are now actively trying to go beyond the basic package. But the way they're doing it is not by expanding the universal basic package. What they're doing is they're creating programs for specific populations with a more generous benefit package. And this is, again, 44 countries in Africa, of which 80% of the countries have a program for the poor, and 60% of the countries have a contributory program for civil servants. This didn't exist often a decade ago, but now 60% of countries already have one. And so the idea is, it is through these population coverage programs that the benefit package is going to be expanded. There isn't a lot written about this, I don't think. I don't think there's a lot of explicit debate about how this is the path of expansion, but I find the numbers striking. 60% of countries in Africa now have such a system. Now, there's huge variation in terms of the quality of implementation. Some of these are full-fledged programs with, very clear set of criteria for prioritization, purchasing, etc. In other cases, it's extremely weak, not enforced. Very often, the programs for the poor, for example, are not financed. But this is partly what's happening. Coming back to the priority setting topic, the Disease Control Priorities Program recently published a new set of results with their recommendations for the highest priority package for low-income countries. And they estimate that this would cost, that providing this benefit package would cost 5 points of GDP. Now, countries are spending, these low-income countries are spending today almost 5 points of GDP. But they're only spending 2 of those 5 points in the universal benefit package. So if to get 5 points of GDP available to the whole population, for that, depending on how the government decides to implement this, it could cost 5%, if they decided to close down everything and provide exclusively those services that are recommended, or if they continue with the same pattern of financing by government, it would cost them 25% of GDP to reach that 5% of GDP financing the basic package, the highest priority package. So partly the problem about priority setting today regarding the next step, what is the next thing that is going to be offered, and how do we integrate the basic package that existed until now into the future, and how do we secure the sustainability of that, have, I think, to do with the problem about lack of clarity, not for a huge chunk of GDP, but say if you can raise your public expenditures by 15%, which is a lot, what should you purchase with that? And it's a very different proposition, I think, than what's being analyzed and proposed. And then regarding the delivery of the prioritized benefits, as I said, not in every case, but in most cases, the trend now is to make the benefits explicit, and very often this allows and invites the development of new contracts and output-based payments, which is also something that you find in most of the countries. Moving now to the population side, there is, this is the population of countries with the poor, the vulnerable, the non-poor informal, and the formal sector. This is obviously a simplification, but basically the point here is that there now exists one area of consensus which did not exist 20 years ago or 25 years ago. And that is that the poor cannot and should not pay for healthcare. And I think this was perhaps one of the changes that occurred during the MDG phase. All the countries we're now studying have a policy of exemption for the poor. Many of the countries, still on speaking about convergence, many of the countries have also a policy about for the formal sector, which is, as I showed in the case of Africa, many countries think that the way to go is to establish a payroll tax to get the formal sector to contribute to the financing of their sector. And the areas of divergence are in relation to the vulnerable, those who are just above the poverty line. Should they be included or not? And many countries think they should. Many countries have this as a very difficult area of debate. In the United States, most of the improvement in coverage from Obamacare was because Obamacare allowed Medicaid to cover not just the poor, but the poor people up to 140% of the poverty line. But now the current administration wants to take that back. And countries also disagree very loudly about what about the non-poor in the informal sector. So I mentioned before that some of the countries were implementing demand-side programs. And these are programs that try to give people an effective demand over areas of care that were previously closed to them. And in general, this involves some form of targeted health insurance for low-income populations. The aim is to give those populations access to hospital care and high complexity. They involve at least a partial purchaser-provider split, which in some countries is the creation of a new agency or a new scheme. Those are areas of convergence. Those are common areas between countries that choose the demand-side programs. And countries diverge, however, regarding, as I said, whether the non-poor informal population should be subsidized or it should pay, and whether this new agency, the new purchaser, should be part, in the countries where a social health insurance agency existed for the formal sector, there's some countries that say this should be part of that. And that's the choice, for example, in this region of the Philippines, Vietnam, Indonesia. Other countries decided that that should be kept as an autonomous agencies. That's the case of the very popular Thai case. So this data by now is a little bit old. It's around 2010, but all we were trying to show here is that there's a lot of talk about how once you have some kind of a coverage program for the poor, then the problem is covering the informal sector. And for some countries, maybe that is the case. But what we found is that at the top, you see that Turkey, Thailand, and Colombia have been successful at providing high, at least nominal coverage for everybody. There's two countries that those are Peru and Vietnam, who have effectively managed to provide high levels of coverage for the poor and the higher income people. But Indonesia and Ghana, in the year when these surveys were taken, had not yet been successful at covering the poor. And yet sometimes the dialogue gets confused as if it was a universal norm that the problem is not covering the poor, that the real problem is covering the middle income groups. And obviously that's a later program. You have to achieve, you have to make a big effort to get to that point. A lot of debate again about the informal sector and covering the informal sector. We were surprised by these results. We frankly did not expect something as stark as this. But basically what this says is the countries with very large informal sectors, all the countries that have an informal sector that's larger than the median, and South Africa, have not managed to cover the informal sector. And all the countries that have been successful are countries that have relatively smaller informal sectors and also lower poverty rates. Now, very important to remember that one feature of growth in recent decades is that very often it does not come with reduction in the size of the informal sector. So patience is not necessarily the answer. Regarding the supply side programs, these are programs, most of the programs we studied, as I said, were based on primary care, community-based care, and we looked at a variety of countries. Some of them are low income, some of them are high income. So the health extension program in Ethiopia, the NRHM in India, in Brazil, the famous, the famous family health program. And what we find is that these are not just investments to make it bigger, but very often what really makes them successful are some very difficult reforms that the countries undertake at the time of making the expansion. These usually include reforms in human resources, which include things such as task shifting, which is often a gigantic effort in terms of politics. Financial management reforms, making sure in countries where there's an environment or a big risk of corruption that you provide means by which managers of clinics have access to petty cash. So I also wanted to emphasize, and this may be very relevant for the countries in the Pacific area, that there is relatively close examples of success which stay in the national health system, in an integrated national health system path. And that is the case of Malaysia and the case of Sri Lanka. In both countries have high and very equitable MCH outcomes, very strong financial protection, low cost because of the simplicity of the system, and they've achieved all of this faster than comparators. These countries provide free care to the entire population. They have a very strong network of primary and hospital care. Malaysia, during the 30 years after independence, opened a primary care clinic every 4 days. I guess that when you do that, and when you have such a strong platform of service as that, which, by the way, was also a similar case in Thailand, then you can achieve those very impressive results. One important characteristic of these two countries is that they have very strong stewardship and governance. The problems of absenteeism, problems of corruption, problems of these sorts of problems are not present in those countries in the same way as they are in some of the neighboring countries. Important, and I understand that to some extent this is also partly the system in Australia, there's targeting by self-selection. There's long wait times, low consumer satisfaction, and that means that these are income levels, and this is outpatient services, very, very strong for the private sector. Utilization of public facilities, outpatient, falls very sharply with income. So about this, in a paper making this comparison, we were also trying to understand what is the limitations of this model, and at least conceptually, we haven't really been able to measure that, but at least conceptually, there's a long list. It's hard to continue increasing health tax financing, hence the temptation to go for payroll taxes or earmarked taxes of some kind. There's a lot of implicit rationing, hence the temptation to go for explicit benefit packages and explicit systems of rights. There's lower accountability than in a purchaser-provider split. The very reason for a purchaser-provider split in economic terms is to solve the principal-agent problem. And finally, in an environment where NCDs become a larger part of the burden of disease, then the need to take population policies and track directly NCD chronic patients may be easier in one context than the other one. So Malaysia has the triple income per capita as Sri Lanka, and the point where countries turn from low middle income to upper middle income is at $4,000 per capita. So this is a suggestion just out of the magic hat. Maybe that's the time when you want to begin considering financial reforms. So final slide. The new reforms bring new risks. It's much more complex, so you need to develop the skills to deal with that complexity. And these are technical skills, but they're also political skills. This is politically a much more challenging environment. There's promises, and because there's promises, there's broken promises. And most of these countries are not doing a very good job at monitoring the three promises. And that's something that's really needed if UHC is going to maintain a good reputation. And finally, in terms of fiscal sustainability, thinking about what to do with a 15% increase in budget is likely to lead to fiscal sustainability. If we're talking about increasing the budget by 20 times for the whole sector, who knows what that's going to do to fiscal sustainability. Thanks.